Hey folks, Scott Weingart here, and this is the EMCrit podcast. Today on the podcast, DSI. We'll talk about that. First off, Happy New Year. I hope everything is going splendidly with your fresh 2024. Before we get into the podcast, real quick, I realize I haven't mentioned it at all last year, but my buddy Haney Malamet and I run the Resus Leadership Academy. Now, what this is essentially a virtual resuscitation fellowship. You basically are getting the 1-year resuscitation fellowship, but you don't have to move anywhere. You don't have to go to a new place. You could keep your current job. We have lectures. We have group get-togethers. You meet individually with amazing critical care and resus doctors. And by the end of it, you will be the top performer in resuscitation in your emergency department, your hospitalist gig, whatever place you want to up your resus game. If that sounds interesting, then get more information. You can do that at resusleadershipacademy.com. That address again, resusleadershipacademy.com, and you will then be one of the best people at resuscitation in your department. So if you're interested in that, if you've always wanted to do a resus fellowship, but you just can't, quit your job and go and take a fellow pay for a year, this is the way to go. All right, let's get into the show. So now I'm going to ask a question, and it's not rhetorical. I'm not just doing this for effect because I've already made up my mind. It is really a question to you, and that's what we're going to discuss in this episode. And that question is, should delayed sequence intubation, DSI, become the standard for critical care intubations? And I really want to hear your opinion on this, so please comment, send me emails, go to Twitter, because I'm still on the fence, but I'm going to lay out my case. And I shouldn't say I'm on the fence. I am leaning strongly to saying that yes, DSI should become the standard now, but I could be convinced the other direction. I'm not definitive. Now, the original DSI paper that myself and some of my buddies did, we looked at patients who were preventing the things we wanted to do in terms of pre-oxygenation or preparation for intubation. And ordinarily what you do is you just RSI them and hope you could oxygenate them during the apneic period enough to make it a safe intubation. What we did instead with DSI, delayed sequence intubation, is we'd give a dose of ketamine sufficient to dissociate the patients, and you'd start with 0.5. Surprisingly, that was enough in a lot of patients, and then you give 0.5 milligram aliquots until the patient was dissociated, and then you do whatever you need to do, whether that's pre-oxygenation regular, whether that's pre-oxygenation with CPAP, whether that's putting an NG tube in for a patient with a stomach full of blood, or positioning, or whatever they wouldn't let you do. And then after you were happy with their preparation, their pre-oxygenation, then you'd push a paralytic. You'd wait the apneic time and you'd intubate them. And since that time, I published that study. It's got to be over 10 years, I think. I've been using it on far more intubations than the original ones in that paper. Because for anything, like the patient just blinked wrong in terms of getting them perfectly prepared to make their intubation safe, I would just push the ketamine. And then I'd have, the ability to get them perfectly positioned or what have you, even if they didn't meet the classic indication for our original paper, which was delirium preventing pre-oxygenation. So I had already loosened my feelings on when DSI should be done before another event happened. And that was very recently a randomized controlled trial was published on DSI versus RSI for trauma patients needing intubation at one center in India. And this study was first author Bandipajay. I'm so sorry if I'm mispronouncing your name because your study's great. And a couple of other authors in the anesthesia world. And I guess we should talk about this study real quick, and it'll lead into the rest of the discussion. So they randomized patients requiring intubation. All of them were blunt trauma with head injuries. The reason for intubation was low GCS. And the RSI group was pretty much standard. They got a ketamine induction, succinylcholine. They got intubated after a pre-ox period of a Bain circuit. Now, the Bain circuit is one that's very similar to an anesthesia gas machine if you're in the United States, because you're not familiar with these. If you're outside, you probably know. These would also be a Mapleson circuit. And they would have pre-oxygenated the patient until the 3 minutes are up. Then they push the meds, RSI style, and then they intubate. In the DSI group, they didn't do any pre-oxygenation until after pushing aliquots of ketamine sufficient to dissociate the patient. And at that point, they pre-oxygenated for 3 minutes with that same Bain circuit and then pushed the paralytic, waited the apnea time, and intubated the patients. Now, in the DSI group, the first pass success was better. And the reason the first pass success was better was that the patients didn't desaturate as much. And that was the primary outcome, is desaturation. And the desaturation rates were much better in the DSI group. They had better pre-oxygenation. And this has led the senior author to say that now all trauma intubations at their center will be done with DSI. I had communications with this author. I'll talk about some other stuff in the study that came from those communications. Now, that was enough nidus to make me start thinking, should we be doing this on every patient as a standard? Not exclusively, like you to be able to do whatever you want for certain patient classes, but should this be our default rather than RSI? And to make that change, I would think the benefits would have to significantly outweigh the risks. And I'm going to make the argument right now that I think they do. And then we will see. Now, what was another nidus for this episode was I had a 2.5 hour debate with my buddy Sam Ghali, and I can't publish that because it was just too long and it would be torturous for you. But what I'm going to let Sam do is, after listening to this episode, if he wants to respond with his points, I think would be great. But one of the things that came up in that was he doesn't think it should be the standard. And so I'm going to lay out this argument, and then we'll see if maybe I could change Sam's mind. Now, I want to be clear here. If I was recommending this as the default, I would not do it the way they did it in the RCT. They didn't pre-oxygenate at all until after the meds were pushed. And in addition, they were using a device that I think is really making it hard to pre-oxygenate a patient who's even the slightest bit not happy with it, right? And what Sam stated about this RCT is like, Scott, this RCT is the perfect testing grounds for DSI. It was originally conceived because a lot of these patients will be resistant to something like a Bain circuit when they might not have been to just a non-rebreather mask at flush rate. And he's probably right. And when I talked to the senior author about that, she said that, yeah, some of the patients in the RSI group were resistant. Some of them were completely schlogged, but some were resistant to having this Bain circuit on. So Sam's absolutely right that in some of the patients, I'm sure the primary benefit, the reason they had better pre-oxygenation is the pre-oxygenation was not perfect in the RSI group, showing the original reason for why we created DSI as an idea. But she has noticed, and I have noticed as well, now, it didn't show through in the study, that the respiratory pattern is radically different once you push the ketamine. This is something I have noticed throughout the years of using ketamine on these patients, is when you do a DSI, their respiratory pattern gets deeper, it slows down a little bit, they stop the dog panting, dead spacing type ventilations, and they start taking these nice big breaths. She noticed this as well. She talked about this independently. I didn't have to cue her for this. So that would be an impetus in my mind that maybe DSI would be beneficial from a pre-oxygenation standard for any patient. But I'm not advocating you do what they did, which is they pushed the med and only then started pre-oxygenating. Here's what I'm laying out as what I think the default should be. I think you pre-oxygenate the patients as best you can if they let you, just like normal. So you get your 3 minutes of pre-oxygenation in with whatever device you choose, whether that be a non-rebreather at flush rate greater than 50 liters per minute, which we know is just as good as a BVM. Hey folks, but we're not getting right to the show because you're listening to the free foam feed of EMCrit rather than the members-only feed. Now, I'll put you out of your suspense. This is a full episode. You're not going to be cut off. Don't get upset that you're hearing this and now 8 minutes from now, you're going to be listening, super excited by what you're learning, and then all of a sudden, and no more episode. You never want to hear that sound again. You're not going to hear it in this one, but you're going to hear it in a bunch of others because you're not a member. And membership is so cheap and so beneficial to the care that you could provide your critically ill patients in the ED or ICU that it's just crazy that you're still hearing this message. So go to emcrit.org/join, become a member, do it before the end of the year. You could write it off on your taxes. You could use your CME funds. And then all of a sudden you get all of the stuff that is not available in the free feed, and you never have to hear this message again. Please consider joining, and thank you for listening. Whether that means a nasal cannula plus a non-rebreather at less than flush rate if your flow meters don't go there, a ventilator, an anesthesia circuit, a Mapleson circuit, a Bain circuit, a non-invasive machine. I'm not a huge fan of high flow pre-oxygenation, but knock yourself out if you like it. All of these have been proven to be okay. You do that for 3 minutes, and then you push the ketamine. But you don't push the ketamine until you have everything ready for that intubation. That should have already been done during that pre-oxygenation preparation period. Everything's ready. Everything's there. Your meds, your failed airway equipment, everything's ready. You push the ketamine. And then you add a delay before you push the paralytic. Now, that delay could just be as long as it takes to say, is there any reason I shouldn't push the paralytic? And in many cases, you will look around, everything is just as you like it. The patient's positioned. You look up, they're sad, it's good. You go through a final check in your mind. Is there anything that's going to get screwed up from a hemodynamic standpoint, from any standpoint, by pushing the paralytic? You answer no. Okay, you push your paralytic. And now, so the DSI, the delay, has been 2 seconds, right? That's just the standard. The standard is not that you're going to wait 3 minutes every time after you push ketamine. The standard becomes that you're just separating the slamming in of your induction meds and the slamming in of your paralytic, which is standard RSI, to instead a nice slow push of ketamine and maybe a lower dose than you're used to because now you have the time to actually see how it works. Nice slow push of ketamine, a stop point, a delay, a checkpoint, asking yourself, is it cool to go further? And if it is, then push the paralytic. So most of the time, in many patients, the DSI will be just 2 seconds difference from the RSI, right? That's the difference, 2 seconds. But in some patients, you have that checkpoint and you say, no, actually, let's do some stuff. Maybe the patient wasn't perfectly positioned. Maybe, maybe I should put that NG tube in because this patient has a GI bleed. Or maybe, I don't like that, where that went with the hemodynamics on that patient. The A-line's now showing the patient got a little bit hypotensive after pushing that ketamine. I'm not going to push that paralytic. I'm going to resuscitate, or I'm going to just do them ketamine-only intubation. And you don't push the paralytic. So that's it. That's what I'm saying is just inserting a checkpoint on every single intubation converts from RSI to DSI, but not necessarily taking 3 minutes. Have them all pre-oxygenated if you can prior to that point. Now, obviously, if they're not letting you pre-oxygenate, if they're not letting you position them the way you want for pre-oxygenation, then just do standard DSI, which means push the ketamine and only pre-oxygenate at that point. But it's not going to be like that for every patient. So now let's talk about the benefits versus the risks, because that's, like I said, is what would have to be the case. The benefits significantly exceeding the risk to change are what has worked for 30 years standard for critical care and resuscitative intubations, which is rapid sequence intubation. All right, so let's talk about the benefits. So the first benefit I'll put up there is if you do DSI as your standard, you could do a dose-finding expedition for how much ketamine is needed. Now, that is good in certain patient classes. The first one that comes to mind is the morbidly obese patient. And I've spoken about this on the podcast, but it's very difficult to know how much induction these patients would need. And my guess is oftentimes it is underdosed. Now, this will never happen if you do DSI with ketamine because you will keep pushing ketamine until the patient's fully induced, even if that's a lot of ketamine, even if that's 3 milligrams per kilogram, 4 milligrams per kilogram IV to get this patient induced, what chances are is you're just underestimating how many kilograms it actually takes. And this way you will never underdose these patients and leave them aware during their paralysis, which would be poor form indeed. The next one is the patient with an innate resistance to ketamine. And we've all seen these during procedural sedations. The patient, you give 2 milligrams per kilogram of ketamine and they're still wide awake talking to you. Well, that patient would be wide awake during the intubation itself. The other patient is the hemodynamic patient. Now, all induction agents, including ketamine, including etomidate, can drop the blood pressure. And whether that's an intrinsic drug effect or just an effect of being sedated, it's irrelevant to me, because I just want to use the minimum dose I can and then know whether or not they dropped from that dose before I paralyze them. Because once I paralyze, I switch them from negative to positive pressure, and that's a real problem physiologically. So I would like to be able to give just the right dose of ketamine and then see what the results of it are, which I can do with DSI. Now, you could argue, there was just a NEARS paper published showing that dose reduction doesn't matter. I'm not sure if that paper's really demonstrating it in the sickest patients that we actually would care about this on, but they might be right. It might be that, at least for ketamine, for etomidate, that the dose reductions don't matter. We definitively know it does for propofol, but that's not talking about the sedation effect itself. That's just talking about the difference between doses. So you could still see this drop even if there's no intrinsic effect of these medications. So just the right dose is the first benefit I would put out there. The next one I've already mentioned. You could have last-minute changes in positioning and pre-oxygenation that you can't get when you RSI because now you have a completely relaxed patient. So what I advocate is, in addition to doing this checkpoint, once you push the ketamine, you do something else, which is you shift them at this point from whatever you were using for pre-oxygenation. Let's say you were using a non-rebreather at flush rate. You take that off their face and you put on a BVM hooked up to oxygen monitoring and CO2 monitoring. And now what this is going to do, don't bag them at this point. There's no reason to bag them. They've been pre-oxygenated. But put the BVM on their face and hold it with two hands. And now this could be the moment you do an end-tidal O2 check. It's built into many machines. And you can actually see, hey, did I hit over 90% on my end-tidal O2? And if not, then maybe do some further pre-oxygenation now under the beautiful dissociation of the ketamine, right? You can make sure the patient's positioning is just perfect because they always are sliding down. They're always moving a little bit. Now you get them perfectly positioned. Maybe these patients want to sit bolt upright. They just won't let you lie them down. Well, you push the ketamine. Now you get them perfectly positioned in a lying down position because it's different. It's not like you just put the head of the bed back. Oftentimes you'll have to add additional padding under their head once you put them at a lower angle. So this is the second benefit. First benefit, just the right dose. Second benefit, last minute positioning and pre-ox. All right, next benefit. We've already alluded to it, but it's the hemodynamics. It allows you to see the results of your induction before the administration of paralytics. Next benefit, pain relief, right? So this allows you to get patients out of pain quicker. And this was the benefit mentioned by the senior author, Dr. Jain, of the DSI RCT is, you could do that 3 minutes of pre-oxygenation and then push your meds, and the patient's going to be in pain for those 3 minutes, sometimes horrible pain, broken leg or something. Or you could push your ketamine and do the 3 minutes of pre-oxygenation after the ketamine. The patient is now pain-free. The incredibly analgesic effects and dissociative abilities of ketamine means this is a pain-free patient for that pre-ox time. Well, that makes a lot of sense, and that's one of the primary reasons they're shifting to DSI as the default for all trauma intubations. Next benefit. The actual administration of intubation meds. Now, I've advocated for a long time that I think the docs should be pushing their meds in critical care intubations, just like the situation with anesthesiologists, right? Anesthetists in Australia. They are pushing their own meds, and that's the way I've always done it. I always push my own meds because, if you have an experienced nurse, no problem. But sometimes you'll have a nurse where they'll push an induction agent, and then they'll flush it, and then they'll wait, and they'll look up at you, and you're not understanding why they're looking up at you, and what they're asking you with their eyes, and sometimes eventually with their voice is it okay for me to push the paralytic? And you're like, well, what are you talking about? I asked you to push the intubation meds. They're like, oh, yeah, but I didn't know if you wanted the paralytic yet. And this has happened so many times. This is why I've taken over grabbing the meds myself. Now, this is not, per se, a huge benefit to DSI because you could be doing that with RSI as well. You can push your own meds. But this allows you to really ritualize the medication pushing. And it's now understood that you're going to push the ketamine, you're going to wait for the checkpoint, and then you're going to push the paralytic. But it doesn't matter if there's a space between it now because they don't stop breathing, unlike an induction with propofol or etomidate. So now you just standardize the med pushing to always push the sedative, wait for them to be fully induced, have your checkpoint, push your paralytic. And even if your nurses are pushing the meds, this becomes now the industry standard for your department. And it makes it, I think, a lot safer because there's no longer this difference between an experienced nurse and inexperienced. All of the nurses will be pushing the DSI style. All right. I've already mentioned the better respiratory pattern that I think augments the patient's potential for pre-oxygenation. Again, there needs to be a study of this. Like, this is just anecdotal from both myself and Dr. Jane. And then the last benefit, if you buy into the benefits mentioned before this, is now you're just training one way. Because what we've been doing right now is there's RSI with occasional DSI. Anytime there's an occasional something, it never works out as well. Versus DSI across the board means that we train one way for everything. And that always is an error diminishment in every situation I've looked at it in. So now DSI becomes the standard. You never need to vacillate from your standard to do DSI occasionally. DSI just becomes the way. All right, let's talk about the risk. I've laid out all the benefits from my mind. You're like, yeah, that sounds okay in some of them, but there's all these risks that are going to outweigh it. Well, I don't think there are. But I'm going to mention the ones that I hear mentioned to me. And this was the same stuff I had to talk about during the original DSI trial. Okay, they're going to vomit from the ketamine. Ketamine-induced emesis happens after emergence, when the ketamine wears off, not as a result of pushing the ketamine. That's not going to happen. And in fact, if they do vomit after pushing the ketamine, their airway reflexes are intact. They could cough it up. It's much better managed than without ketamine on board. So the other thing ketamine allows you to do is, if you think the patient's at risk of passive regurgitation during the intubation or vomiting, you can place an NG tube very easily, which is very difficult in patients who are agitated in critical illness. Otherwise, they don't like it because it's friggin' miserable. It's not miserable when you have ketamine on board. You could absolutely get the NG tube down. And I do this routinely for things like small bowel obstruction or a full stomach of blood from a GI bleed. All right, so vomiting I don't think is a real risk. Apnea. Now, first of all, this is not a significant thing. Now, people always talk about the apneic effects of ketamine. Ketamine, if you slam it in, will keep a patient apneic for a few seconds, 5, 10 seconds, and then they'll start breathing again. If you don't slam it in, it doesn't happen. But even if it does, it goes away very quickly. It is not a risk. But if you ever had a patient who had apnea more than 5 or 10 seconds, then just push your paralytic and you're in the same place you would have been if you had just RSI'd them. So again, this is not a risk to me. Laryngospasm, always spoken about. It's a thing in pediatrics. I've seen it. It's scary. It's not a thing really in adults. There's been 2 cases in the entire literature extent up until now. And in both of those cases, no one was looking at the actual larynx to see if it was really laryngospasm. Because I'll tell you, what is dubbed laryngospasm with ketamine is almost always just a situation of poor airway positioning. And if you just, reposition the airway, then that sound you're hearing, which is just them breathing against a closed glottis, versus laryngospasm, which is a continuous spasm of the larynx. It's just the patient's airway structures are blocking their passage of air in ketamine in adults. You just position the airway and they're fine. I've never seen laryngospasm, and I think I've used ketamine more than almost anyone out there. In adults, it does not happen in my experience. But if it does occur, then just push the paralytic, and you're in the same place you would have been if you had just RSI'd them in the first place. Hemodynamics, no worse than in standard RSI. If you're using ketamine as your standard, I think ketamine is the standard now, right? Ketamine is the default. Then it's not going to matter if it's DSI or RSI. I think it's going to be better with DSI because you're using a lower dose. Now, even though the near paper said it doesn't matter, I think it's still, I personally feel it still does matter in really sick patients. So you're finding just the right dose. So it's certainly not worse than RSI, and I think it's potentially better. And then hypersalivation, which is a legitimate side effect of ketamine in adults. I mean, in kids too, but I'm saying the laryngospasm is not in adults. But it's going to be better with DSI than RSI because this is a dose-dependent side effect. Hypersalivation is dose-dependent. You're going to be using a lower dose with DSI, the bare minimum dose, and therefore hypersalivation is less of a risk. So I don't see any risks to making DSI the standard. Now, it doesn't mean you always have to do DSI. If there was a patient you thought RSI was a better move, go for it, right? No one's barring you from RSI. It's just which one becomes the default, which one we have as our standard operating procedure, which one we teach as our standard to our learners. And for me, I think DSI could be the better standard. I don't think there's any situation where it's really contraindicated. I guess the only contraindication would be a situation you don't want to use ketamine as your induction med, right? And that would really, I think for me, only be in patients who were so profoundly hypertensive that I couldn't control them. And then the sympathetic release from the ketamine may be a problem. But honestly, most of those patients are already fully sympathetically released. I have not noted that ketamine raises those patients' blood pressure. I've used ketamine in escape patients, with sky-high BPs. to tolerate their non-invasive, which I know is going to fix them and avoid intubation. And their pressure hasn't gone up. It's actually gone down. So I don't personally see any real downsides to making DSI the standard. And if that's true, then if there's even a small benefit that you buy into from DSI as the standard, and I listed many of them, and there's no risks, then there's really no reason not to make it the standard, even if there's a small benefit, right? So, but I'm super curious to hear what you have to say about this, right? I'd really love to know. So let me know. Come on over to the show notes for this, EMCrit.org/366, or hit me up on Twitter and tell me, am I wrong? What have I missed? It could be anything, because I am not omniscient. So if I'm missing something, tell me. And I would love to have my opinion changed. And again, I'm asking this as a question. I'm not telling you definitively do this, but I'd love to explore it with you because I think it probably could be good. All right, remember the Resus Leadership Academy. That address is resusleadershipacademy.com. One more quick mention here. And so I'll just say goodbye now, and then I'll let that quick mention happen. Scott Weingart from the EMCrit podcast saying bye-bye.